if you accept the premise that an increasing percentage of what we do in medicine is managing information, well, information has very little physicality to it. And just as an example, I've been heading up the development of this general neurology service, which is, take the word neurology out of it. What it really is, we're trying to understand what are the workflow elements, the components, the business model, all elements of it, of delivering more routine type of care to people that aren't in an emergency room with an ER doc right there, a nurse right there, and a video card, with an acute problem that has 3 questions and 1 decision, right? I mean, we're trying to move it more broadly than that. A patient with Parkinson's comes in and they have lots of medicines and they have an infection and it's 3 days later and the family has questions, how do you take care of something like that? And a lot of the resistance, even among doctors, has been that, but then you're not physically there and you can't touch the skin. And it forces you to step back and ask yourself, what do you actually do in the process of medical care? And any doctor that's working with electronic medical records will tell you the percentage of time that they're spending touching patients is really small. You could argue whether that's good or bad. But that's because what they're really touching is their data, their information, their psyche, their communication needs. Everybody, physician will tell you, in neurology, 99% of this it's the story that I get. Well, if it's the story I get, I can get that story by looking somebody in the eye and being 10,000 miles away. As long as we can speak language and our bandwidth is okay, and we're not getting interrupted with audio and video signal issues. When we accept the fact that we're fundamentally managing information, then you almost ask yourself, why would I physically show up to see that person? What in other words, rather than, I can only do so much because it's not as good as being there, I would argue that you turn around and go, actually, being there isn't always better, right? If I'm remote and you're in your house and I'm interacting, first of all, you're in your house, not the office. Second of all, I can look at a CAT scan while I'm talking to you. Harder to do if I'm sitting in a room with you, right? I could be sending messages out to a cancer doctor in Oregon asking for their opinion about this screenshot that I'm about to send them while I'm asking you some other questions. And by the time you then say to me, gee, what would another expert say? I go, funny you should ask. Just got an input from someone. That would be impossible to do if I was physically sitting with you. So what we're trying to do is bring experience and expertise and compassion and a certain amount of knowledge and training to bear in an increasing array of scenarios. And a decreasing fraction of those scenarios is the physical presence of a patient and a physician. And even in the normal care of a person who has cancer or whatever, what percentage of their care is occurring in an office with a doctor as opposed to emails and communications and phone calls and faxes and records? It's a very small number, and it probably always has been a small number.